Hey everyone, this is the Manips and Sips podcast featuring me. I'm Dr. Jeremy Boyd, partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about principles versus methods. There's a lot of methods or styles or camps and tribes out there in physical therapy, and can kind of, push people one way versus the other before they develop some foundations and those sort of things. But before I get too much into that, let me pass it off to Brandon. How's it going, bud?
Going well. How's everybody doing today? Jerry, I know you're at work. I'm at work.
Yep.
I want to preface that as we're trying to squeeze this podcast in, to be consistent and keep the momentum rolling. So I am deviating from my normal whiskey, and I think the last episode I had a beer, so I've been messing up. I need to stock up in the office here. So I'm drinking a Truly. So make fun of me, Jared. I know you will. I have a story behind this, so I'll just tell it real quick. I had an older patient. I think he's in his early 70s, like 60s. And one week we were talking. He's like, "What are you doing this weekend?" And I said I was going golfing, and that I like to drink these with some vodka added to them. And the next time he came in, he brought one in. I don't know where he got it from, but he brought it in. So this is the only thing I had that had alcohol in it. Here at the office today. So this will be used in our podcast to hold true to the sips component. Jeremy's, laughing pretty hard right now. So say what you will, and then Jared, what are you drinking?
That's cute, yeah, man. It's a pretty basic girl drink. Crack that back. Basic white girl,
Gotta be careful.
Oh my God, truly. That's what you should say as you have it. That's the most adorable thing we've had on the podcast.
Tastes like a 7-Up now.
Yeah.
It's basically a 7-Up. This is
That's I really have a room to talk, because in my office we don't have any really like breakout rooms or private rooms. It's kind of open floor space, so I'm doing things from the bathroom / office. So that's where the real paperwork goes down anyway. So I'm drinking today. It's Sweet Canning Graphic, the Axe, by our local, literally across the street brewery. One of my favorite breweries, probably my favorite microbrewery of the smaller scale. Axe and Arrow, awesome people. Probably coolest name. There's, I guess, 3 total owners: husband, wife, and a friend. If I forget who's who, but their last names, one, if you break it down, one's the Axe and one's the Arrow, based off it's like German, each one of them, or something. I could be messing that up, but really good double IPA. I've had it in the past. Gonna have it. Oh, and the cup today is World's Best Boss.
Very nice.
Given by an employee. I'm not that cocky. He did give it to me. That was many years ago, so it's probably gonna scratch it out, put Worst Boss. But anywho,
Cam, I'm assuming got that.
Cam got me that, my first employee here.
He definitely didn't know any better.
Yeah, he was just trying to sweeten up that Christmas bonus.
Yeah.
I know you're not supposed to be drinking these things out of mugs, but it's tradition that I have it out of some sort of cup here. But
good. I've been drinking mine out of mugs that were gotten for me, so
there you go.
It's all true.
Yeah. I give it, on the Jeremy Boyd Manips and Sip scale, double IPA, 8.3 at least.
Gotcha.
It's a solid one.
Your last one, your 8.2 one.
Huh? Yes. No, this one I do like more than what was that? What was that? Oh, what did I have? Shoot. So, dude, my memory already sucks. But this one's better. It's probably one of the better beers I had on the show.
Narrowly beats it out.
Yeah, it's a problem with drinking. Can't remember what you drink half the time. But let's go back into what the show is going to be about today. Go ahead there, Brandon. I know this is something you wanted to kind of get off your chest.
I'll give everyone a little backstory on how I got to this point. And I was creating, and we were creating, I should say, our virtual manual therapy mentorship that's actually launching probably this weekend or next Monday, which is June 22nd, depending on when this airs. But I was writing it up and trying to say, what makes this different and what makes what we're offering and what the problem is out in physical therapy that we're seeing, especially now that everyone has access to any type of information, and you have all these gurus and self-proclaimed gurus out there selling their stuff. And I'm not knocking that, but I think where a lot of PTs, especially newer grad students, and clinicians out their first 1 to 5 years, maybe 3 years, something like that, run into some problems. Or they jump in because they hear about this cool course they should take, or so-and-so's method, and that person treats X amount of athletes, and they're the person to see, and they go down this rabbit hole that they're not ready for, and they don't have any true foundation to build off of, which a foundation would be a principle. They don't have pillars to build off of. And they take these gurus or these method courses, and they try it, they get frustrated after a week or two, and then they're like, this doesn't work for me, and they keep doing that. Then they take another course and the same thing happens, and next thing they know, they're down however many thousands of dollars, and they're 2-3 years in their profession, they still don't know how to treat. And I'm speaking that from not personal experience. Luckily, I was able to avoid that early enough on. But people have come up and told me, "Hey, I've taken X, Y, and Z, and I still don't know how to treat." And I will say I was probably on the cusp of that, because I was taking all these random method courses or treatment type courses, and then luckily, I joined the residency right out of school, so that kind of helped me with that and kind of steered me away from that method or path. But I was definitely going and taking manual release courses, instrument assisted courses, dry needling courses, all these technique based or method based courses, and I didn't have a framework to then know how to use it. So that's kind of my long-winded explanation of how we got to this episode today. But I'll pass it off to you, Jared, just so we pass it back and forth. But I guess what do you feel? What's been your progression? What have you seen? You have an employee, and Justin, who's in a stud therapist and in a residency program. You obviously mentor a lot of kids, and people reach out to you probably now more than ever. You're always sending me screenshots of people asking you advice and stuff. What are you hearing? What are you seeing? What's your take on this?
Yeah, I couldn't agree more. I guess the first true con ed I really did was I did a couple things in PT school. It was like a Maitland examination thing, so it wasn't so much treatment based, and one other thing, and then just went right into the residency, which helped develop that foundation. But I viewed a lot of, at this point now, where I have the foundation, I start to dabble in. I took a BFR course, taking some weightlifting courses and those sort of things, or treating weightlifters. Those are I kind of view those as spices or little appetizers or sides. They're not the main course sort of thing. They're designed to be, give you a tool once you've already figured what is going on. None of these courses, and I still have yet to be at one which helps you out with any ounce of differential diagnosing, which I think is the most pivotal thing to learn in orthopedics or sports therapy. I don't know how acute care works. I'd probably kill someone if I had a line that I had to work with. I'd trip over it, step on someone's catheter or something. But, none of them provide that. And sure, learn all these cool techniques, even going into manipulations or dry needling or some release stuff. It's great to have those, but if you don't know what's going on and how to diagnose the individual, then you're just going to be treating symptoms. And that's the problem. And I think there's definitely an issue, especially with con ed. I feel like the people with the coolest names neuro release functional therapy, NRXTY. It's like, oh shit, and they have cool graphics, and then good for them that their graphic game's all on point there. That, that attracts a lot of people, but again, doesn't teach people how to, really figure out what's going on with the person, and then you can implement some of this sort of stuff. So, yeah, behoove individuals to learn the foundations, get a good figure out how to see what's wrong with the person, how to modify those things, and then add all that other crap if you want to, but that's up to you. So
I guess question / clarification, because I would say your Maitland course that you took, your examination course, is something that people should take.
It's a good course.
Maitland's like a forefather in the world of orthopedic physical therapy, manual therapy, differential diagnosis, things like that. So I just wanted to make that delineation for the audience, because I know what you meant. It sounded like you kind of lumped everything. But
yeah, and
those
that
are the courses you need, definitely.
Yeah, that one wasn't even a treatment-based course. I think we learned one or so minute, but it was, if you know the Maitland system, it was M-0 or M-1.
I think one.
It was just purely examination techniques.
Yeah.
That whole course, imagine a whole course on that, was purely going over special tests, how to assess joint play, all that. So it was purely, and that's why I took it, was I wanted to better figure out how to figure people out, if that makes any sense, versus, jumping into treatment when I don't know what to treat, unless it was a script. But then I'm just believing, a physician, nothing against family physicians or anything like that, who've gotten, 72 days worth of musculoskeletal in their curriculum.
I think in med school they get a week of musculoskeletal.
It was a week.
So define week. 3 days? I don't know.
Yeah, it really depends. So are you going to just rely on the script and then throw in all this fancy stuff? No, I personally took that course to learn how to better examine people. And it's all, again, a lot of special tests and sets or stuff, which is funny because at this point I don't use much special tests at all. But at that point I did, and just made that a little bit better for me. So yeah, I thought that was a fine course and that sort of stuff.
Yeah, so, you probably don't use special tests anymore because now you realize a lot of them suck, and you're probably using groupings and cluster, but your examination yields better results than a special test. And I want people to understand that it's in the examination. It's like you said, it's in the differential diagnosis and not the treatment. And I think early on, and I felt for that early on, we think, oh, this technique, this method is going to help this person. So we try and take all these method and technique classes and we end up nowhere. If that was the case, if kudos to, it's not about marketing, but I think PTs need to not fall for the gimmicky marketing bullshit that's out there and understand what's going on. Because if that method was really as good as it is, doors, you would take it and your door would be filled for months on end. You'd have a waiting list. Instead people need to learn that it's about examining. If you could examine and differential diagnose, then you know how to treat. Then those methods become important, because you now know how. Okay, for this I need this. For that diagnosis I need that. And I think that delineation needs to be met and made clear with what's going on.
Absolutely,
so,
like
you said was good.
I don't know, but I feel it's probably the same. The time I spent over working with you. Just hearing patients talk, they would always say the main thing that they harped on was like, wow, your examination is more thorough and hit the spot than anyone else I've ever been to. It wasn't that I was like doing a lot more like, oh yeah, let me just, I got an hour, let me just fill this with, 20 tests or just bullshit questions. No, it was all purposeful sort of things. And it's like, yeah, most of the time, table went out from out me, that, I'm figuring things out, and half of it's more towards treatment. And why is that the case? They feel like it's thorough because I know exactly what I need to examine. Yeah. And, I feel like I think the standard is generally an hour for an eval. So all these other therapists that all of my clients have had in the past, they've had the same amount of time, but again, they're just not hitting the right marks, clearly, because, then they wouldn't have to see us. But yeah, that's something that I see is, invest heavy into, if anything in real estate, stocks, anything like that. Invest heavy early on, like into the examination process, into your differentials. It's going to set the rest of the road much easier. Same with your career. At least I personally believe that. Obviously, me and you are biased. We invested in the residency that cost money, time, everything like that. When we didn't have money or time, young individuals just starting their careers. But that, kind of led to all the things that we have now: ownership, teaching opportunities, manual therapy sort of stuff. So that's how I believe it. And when it comes to those sort of things, but if I didn't have the foundation to figure out what to do in that examination, I wouldn't have a practice. I'd just be like anyone else. And it wasn't like, it was just big corporate places. I had people coming in from other private practice physical therapists and, same results, unfortunately.
Yeah, I want to, and like you, I mean, we've had that, patients have both told us and even written on our reviews. I've done more here in, a 45-minute session, hour session than 6 weeks with someone else. And that just goes down to, knowing how to treat. And I want to use two topics because I think that we can kind of talk about these and they're not necessarily claimed by one person who, could kind of get us in trouble for blasphemy. You got to be so sensitive in the world. But BFR and cupping, I'll talk about cupping as an example between a method versus or a treatment method versus a principle. Like, people rushed out to take a cupping course to learn how to literally put a cup in a nozzle, hit the trigger twice, and then have somebody do a cat camel for low back pain, or have someone go into a child's pose for low back pain. I'm not trying to put anybody down, but if you needed to spend $500 for that, I mean, one, you should probably take a look at yourself as a clinician, and two, like, what are you doing? Why can't you just take principles? Again, this is where if you had principles of direction of preference, movement preference, a knowledge of mechanics, a knowledge of some other scopes, whether it's yoga-esque or just general basic exercises, and you combine the two together, you would be able to derive on that. I mean, I bought a cupping kit for $15 off Amazon, and I could throw on cups and have them. I could combine it with nerve glides. I could combine it with joint mobilizations. I could combine it with movement. I could, you could combine it with dry needling if we had dry needling in New Jersey. I mean, you just have to understand what you're doing and what's the desired outcome you're trying to get, and not just, here's cups, here's back pain, let me put it on their erectors, let them sit for 5 minutes, maybe do some movement and hope for the best because I was told in a course that cupping is going to help low back pain. No, if that's the way you treat, you need to really take a step back and evaluate your principles and what you're doing and your foundations, and you're probably doing your patients unjust. And I'll let you talk on BFR, Jared, because I know you're more accepting of it right now than I am, and you've taken a course and you could probably speak to it better than I can. But BFR is another one. People are rushing out to take courses, and for what? Like, I had a former employee go out and take it, and he's like, I'm taking a BFR course, yada, yada. I'm like, okay, cool. But you just told me that you feel like you don't know how to treat after 3 years of practice. Why are you taking a BFR course? What population are you going to use BFR on? I asked him this, and he said, ACLs. I'm like, okay, cool. How many ACLs do you see in a year? He answered me saying 2 to 5 ACLs he sees a year. So why the fuck are you taking a BFR course for, I don't know, $1,000? And then if you buy the real nice kit, it's about $5,000 to $7,000. I know you can get these generic models and knockoffs and stuff like that for cheaper. But again, if you're seeing 5 patients a year, is it worth taking that course? Like, to me, your values as a clinician are skewed. Now, if you're seeing high level athletes and you know it works and it's justifiable and the research that you've read at least supports it, and you know at what point in time in the patient's care you want to integrate this and not just slap it on day one, cool, I have no problem with it. But if you're just taking it because it's a new trendy technique or method, there's a problem. But I'll shut up there and I'll let you talk, Jared, because you have more knowledge on that than I do.
Yeah. So a little backstory on that. Justin, our other therapist here, we had I guess a client with a sleepy quad per se. At least that's what the surgeon said, and he was adamant about she needs BFR. She needs it. And that was it. I was like, yeah, we believe it's some other things going on, blah, 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 blah. And I have a policy here, whatever the patient needs, we're either going to get, but we invest in training because I believe the training, that's all you need. You can have what is it, Scott and Bill, one of them, I think it was Scott, was a really great therapist. All they need is essentially what's behind you right now, Brandon, is a table, a couple bands, and a couple dumbbells. You can figure out anyone in your mind, right?
Just to that, I started my practice with a massage table in my hands and mini bands, and made my money that way before I grew.
Yeah, if you saw Ghetto Trifecta,
all the nice stuff and shit. What?
Yeah, saw Ghetto Trifecta when we started off. Yeah. Like I have pictures of it. It was literally some
nothing to be ashamed of.
Beat up tables and literally a couple of pieces of equipment. And within a couple months, it was getting professional athletes because of not the facility. The facility looked like shit. Not the equipment. There's plenty of high performance places. It was basically the skill and people word of mouth, like, oh, these guys know what they're talking about. But regress back to BFR. So weekend was straight. I think my wife was away, so I was like, oh shit. It was a BFR. Yeah, I was like, oh shit. So most people would probably like do something relax.
His wife's like, weekend to go have fun. He takes a course.
Takes a BFR. I think that happened with USA weightlifting too. It's like, yeah, she's away. I was like, yeah, fuck it, I'll just take a course. More for just me, just to get better at weightlifting, but and just to know like what weightlifters are going through. But anyway, so I take it and everything like that, and we do see a decent amount of ACLs at my clinic. In all honesty, I mean, I follow the protocol. I've read the research. Most of it's based off of ACLs, and I don't think it's that great for it, in all honesty. Maybe I'm doing it wrong and those sort of things, but yes, can they do things at a lower load and volume and get similar physiological effects? Yes. How it feels on a patient that just went through a pretty shitty procedure and they're in a lot of pain. They're already fatigued with just their quads and those sort of things, and this makes them more fatigable. Just personally, anecdotally, I find that it's either kind of a null effect or almost counterproductive at times. And I always ask every time they come in, I'm like, what do you think is working for you? What's not? Oh, we implemented this. Do you think it helped? Obviously, you can't base something like BFR off of one session or something like that, but they'll start to tell you, and things that aren't working, they're like, yeah, it's okay. They never, people are too nice to say, oh, that sucked, or that didn't help at all, or anything. Like, yeah, it's okay. And I've noticed it, and I implement it to try and implement it, but I weed it out. Have I from other things? Like I don't even know how it was. I think I might have had an ACL client on it or something like that, and we might have done like a glute workout, and they reported the next day that their glutes were like crushed, or they felt like they really worked. I've used it for some people. I think, is it Cook or Stu McGill talked about like glute amnesia. I forget who talked about glute amnesia as like that's a thing in the United States. I have a couple of clients that they couldn't activate their posterior chain or their glutes if they wanted to. Have I used that BFR for that? And I've had anecdotally, no research, worked very well for. Maybe the theory of, the bias work with less blood kind of circulating in the system, so it makes all the muscles kind of fire in. yeah, I've had it work, but I would have never gotten to that point unless I had the foundation of being able to be, have good differential diagnosis to realize, their glutes aren't firing, or the lack of their glutes is contributing to their symptoms. Because let's face it, a lot of people in America, their glutes aren't firing. Is that the true cause of what's causing their symptoms, or they're just, like everyone else, where their glutes aren't firing? So if I wasn't able to connect those dots, would I ever make that intervention? But yeah, that's my long-winded story on BFR. And, I wouldn't necessarily jump to it. We can jump to it because of a surgeon had it. Would I have been able to do all the things that we're doing without it? Probably. Yeah. But that's my opinion. It's long-winded.
I just want to add some, like, with the ACL component you're talking about, and being able to, first couple days of somebody after surgery and they're in your clinic, to be able to load them up. But what's the point in loading somebody if they don't even have that neural connection to make a quad set or to do a straight leg raise? I mean, I think there needs to be some prerequisites before we start to slap on some cuffs and sleeves. If somebody doesn't have that neuromuscular control and that connection from the brain to the quad to be able to contract their quad and lock it in, what's the point in loading? That's a neuromuscular issue, not a strength issue. Yes, it leads to a strength issue, but it's coming from a different place. So I think people need to just take a step back and have a better understanding, and not have a shiny new toy syndrome, with some of these things.
Yeah. Toko, who's the director of my residency fellowship, he always says, find the cause of the cause. So yeah, again, it could be a strength issue, but you have to know it's your differential, or just a good examination process tells you that's a neuromuscular issue. You have to find that first, or you can slap it on, and it's just not going to get anywhere. And that first client, she got her BFR, it didn't really make much of a huge impact.
Yeah, take somebody with lumbar radiculopathy and they have foot drop. You could strengthen that anterior tibia all you want
all day,
but that cause of that foot drop is coming from their back, coming from that nerve, which is coming from the back. So it's the cause of the cause. But yeah, that was pretty much it. Just kind of wanted to make an episode about that. I guess one other story. I mean, I was big into, anecdotal. Actually, real quick, back up. You said anecdotally, it's not research. Jay, you put that anecdotal story into a case study and publish it, and now becomes research. I think, we need to be able to, really discern and how to appraise research and not always just rely on
what's out there. Yeah. I mean, me and you talk about all the time of all the cool things that we're doing, and seeing consistent results. It's cool when you get a case report or anything like that, but when we're seeing consistent results. Justin, he's doing a case series on doing cervical mobilizations with nerve glides and those sort of things, so he's finally getting it to publish there. Obviously we're limited on time and being able to do that. I'm trying to put up one. But yeah, I could easily do that. And again, we put a lot of, and I think that's a problem with research now, we put a lot of weight on what's out there versus, using our, clinical intuition a lot of times, but get to that point. So,
I guess another thing, just kind of while we're here, and I was a proponent of
that much beer.
FMS. I dove into it hard. I liked it. It gives you a nice framework. It definitely helped me understand movement and better, and regional interdependence better, and just performing a screen better. But I think it also has its limitations. And all the props in the world to Greg Cook and where he kind of pushed, I think, at least from where I was, and maybe it was just because it was my era, I think he kind of put and combined physical therapy and strength conditioning worlds, or the movement worlds, together pretty well in the late 2000s, early 2010s. That was probably that era. Awesome job. But, talking about principles versus I guess methods and techniques and gurus and stuff like that. Like that's kind of like a perfect example, like a hybrid of both. I mean, he had some strong principles in there, but when it came down to it, you're utilizing a system created by a person that, you know, also has some holes in it. So, you know, it got to a point where it's like, all right, I'm doing this, but this isn't getting all my patients better. And I need to be able to learn how to use his framework, but then be able to deviate and pick up the patients that aren't falling into, you know, his classifications and boxes and breakouts and stuff, because all that is a cookbook of, if it's this, go to this. 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 And that's just, you know, a cookbook and a guideline for you, but you need to be able to learn how to break away from those guidelines when applicable. So I think, you know, he was probably the closest person who's able to try and bring both of those together. But even still, there's going to be some limitations in there. And you need to take a step back and understand and develop, be able to double down on your exam and your differential diagnosis and referral patterns and pain patterns and mechanisms of injuries and things like that to really understand how to treat someone better and not just jump into those treatment and method courses.
Yeah, absolutely. I mean, I don't think you can ever truly, as much as you want with research or good course, I don't think you can ever truly cookbook an examination. I don't think you can. I don't think there's going to ever be enough research out there that can truly adapt to every unique human individual based off of their activities of daily living, their previous experiences, their body type. I don't think you possibly can. But they did a good job of, you know, at least, you know, little things and those sort of things. I had a guy recently just ask me, it's like, once a year he goes for SFMA assessment and wanted to know if we did that. I was like, yeah, I've gone through it and those sort of things, but I no longer assess people via the SFMA style.
Solely.
Yeah,
solely via the SFMA.
Yeah, I integrate some things and those sort of things. We've taken like a TPI course that had some SFMA, and we went down there. Yeah, it's for golf. I picked up one thing that I could integrate into some of my exams, but it's never purely off of that stuff anymore. Listen.
Sorry, were you going to?
No, it looked like you wanted to say something. So I was like,
yeah, because you said something about that, and somebody wants to see you for SFMA, and it spurns something. And I've had this conversation before. I remember when I first started up, I rented space out of a gym, and I was doing just a lumbar screen. And I want people. I'm saying this because I want people to make this connection and be able to discern things. And all I did was just have the patient bend down, touch their toes, put their hands behind their back, do a lumbar extension, side bend, run their arms down the side of the leg, and do rotation and a quadrant test. That's all I did, right? And a trainer comes over to me, and he's like, "Oh, you're doing an SFMA screen. I like it, blah, blah. I'm going to refer you patients." I was like, all right, cool, whatever. I just kind of let it be. But I'm like, that's not an SFMA screen. Awesome, great cook made it that popular. That's just a lumbar screen, simple lumbar range of motion screen. So, you know, if you take a step back, a lot of what he did is a simple screen. I mean, him going here to here is range of motion testing. Mm-hmm. Him looking up is range of motion testing. You should be doing that anyway. You don't need to take that course to understand. You should. Half the test is this, athlete scratch test for mobility, lower lumbar stuff. He does child's pose, which is yoga as a clearing test, and Yoakum's AC joint pathology test. And, you know, now you have the SFMA. If you understand where the stuff is coming from, and that was another thing. I think going through the residency, I got an insight to the history, and then I geeked out and downloaded everything and read everything possible, knowing I had free access to like a really good database. And then I was able to realize, because I had taken the FMS and read the book and everything before, I was like, wait, this dude is just repackaging an orthopedic screen in a much friendlier, simpler way. Mm-hmm. All this stuff a lot of the stuff that's coming out, you go to like anatomy trains and stuff like that. I mean, these things are just repackaged. I think the story goes, don't quote me here, that Gray Cook, when he was making the SFMA, went to Shirley Sharman, right? That's her name, Shirley Sharman?
Sharman, yeah.
Sharman. Because she had her movement and philosophy principles in, I think, the 80s or whatever, 90s. And he went to her trying to basically build upon what she had started. Apparently she wasn't on board or nixed it or whatever. So then he started his own thing. So all he did was just take an extension of, some physical therapy principles, movement principles by a very good therapist in Sharman as well, or Sarman, and then kind of repackage it into an updated version. I think we need to understand that and see that. I did have another point I was going to say, but I can't remember right now.
That truly hitting you, dude. That's
yeah.
It's better than Everclear at this point. It just
5%. It's getting old. That's what it is.
Yeah.
Never living this one down, huh?
No, I'm gonna bring that up pretty frequently.
Now this is recorded and it's for the whole world to see, so I'm really screwed.
Yeah, you're
like, no, I don't drink those because someone could just pull this up. I'll be like those politicians who say, no, I did not do anything, and then they pull up.
And then 20 years later, like, yeah, but you keep busting your chain about, you drink girly basic white girl drinks,
Yeah.
Well, does it taste good? Is it?
Honestly, tastes like 7-Up. And then it has a lot of carbonation. I'm not big on carbonation. I don't drink soda or anything. So, like, a lot of fizz is too much. That's why you put vodka on it. It kills the fizz. And then it's just, you're drinking, like, vodka and seltzer flavor.
Yeah, drinking 2 alcoholic things at once. I guess that could be more, badass. But,
damn it. I forgot my last point. It was a good one, too. Oh, well. I guess we'll wrap on. That's a sign.
We'll wrap that up. We'll wrap up at that point.
Yeah.
If it is another good point, we'll just make another episode out of it.
Yeah.
Hopefully gave some insight to some people. If you have any, comments or arguments against our ideas, we welcome them. Feel free to reach out to us at Nips and Sips on Facebook and Instagram. Also, you can reach out to me. I'm the Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. But thanks for listening, everyone, and cheers, everybody. I still got a little beer left.